Good morning, everyone. At the outset, I would like to congratulate the team Neonatology at SGPGI for this Foundation Day, which is such an auspicious day where we have the Mother's Day and the Nursing Day. Both of them are the major pillar for our neonatal care. I would also like to thank Dr. Kirti and her team for giving me opportunity to be part of this August Guardian and Academic Feast. Over the next 20 to 30 minutes, what we shall be discussing is simple concept, which is a fetal and a transitional circulation, and any disturbance of which leads to PPHN. So this would be a little monotonous, little boring topic because this is the fact that we are discussing about, not the newer or the recent advances. But anyway, I'll try to make it simpler and understandable for everyone. My talk shall be covering under the following heading, where we shall be looking at the anatomical landmarks or the anatomical development, the physiological changes, what happens when the baby comes out, that means the transitional changes, and what is the clinical relevance, a bit about of it, so that you have a benchmark or a base for the further understanding of the topic. We all understand that our fetus is actually a complete parasite dependent on the placenta, from where it gets everything, starting from oxygen, nutrients, antibodies, and it actually clears all the waste what the baby produces. The source or the connection between the placenta and the fetus is what? It's the umbilical artery and the umbilical vein, which there are two umbilical arteries and one vein. This is the basic concept which we all understand. Before I get into the actual business, let me tell you there are a few characteristic features which a fetal circulation has. One, we always say that there is a right and a left ventricle function, which is independent of each other. The concept of circulation in parallel versus circulation in series, which means that two ventricles are pumping independently in their vascular beds, vis-a-vis when they are working in synchrony. Actually, for understanding, we have made it as a parallel circulation, but if you get into the deep details, you realize that the same function, what is there in the postnatal age as a series circulation, is seen in the fetal circulation as well. So the concept of parallel and series is little debatable. The second concept is what? That even a single ventricle is able to sustain the life in the fetus, and that is the reason when the baby has got even a single ventricle, physiology is surviving inside the uterine cavity, but the moment it comes out of, then the problem starts. The third, we all know that right ventricle is the dominant ventricle, and why is it so? We'll see in the subsequent slides. The fourth, the size and orientation of a cardiovascular structure, which means any chamber, is determined by two. One is the flow pattern and the volume of blood through which it passes. So this will make us understand that whenever we have a congenital heart because of any reason, the entire pathophysiology is dependent or guided by the flow pattern. So this is the four characteristic of fetal circulation which we have. The basic understanding is that we are having a low vascular resistance in the systemic circulation and a very high resistance in the pulmonary circulation. This is the basic concept that we have to understand. Okay, so the first thing that we discussed about the ventricular function, how does the ventricle function in the uterine cavity or during the fetal circulation? We'll have to understand about the few shunts which are existing in the fetal circulation. There are majorly four central shunts what we talk about. One is the ductus venosus, which is actually which joins with the placental venous return, which is coming into the from after oxygenation from the placenta to the systemic venous return, which has to go to the heart to be pumped into the body. The ductus arteriosus, which primarily connects pulmonary arterial circulation to the systemic arterial circulation, so that the upper part of the body gets a better or a more oxygenated blood, and it is a bypass which happens. The third connection is what? Is an umbilical artery. What it basically connects the systemic arterial circulation of the fetus to the placental arterial circulation. And the fourth is what? It is the foramen ovale, which has got a connection between the two atrium. So these are the four central shunts which are functional in the fetus, which helps the fetus, despite having a low oxygen and other parameter, to have a streamed oxygenation to the important vital organs and a less circulation to the less vital organs. The same thing can be seen in this picture where we can see so that it is better understood by everyone. So we have a foramen ovale where we can. So we have a foramen ovale which is in between the two atria. The ductus arteriosus is connected between the pulmonary artery and the aorta. The ductus venosus which takes the blood from the placenta to the systemic, to the main venous return to the heart. And we have the pulmonary artery. Okay, I should not be touching it. Now, continuing forward, if you look at the function of the fetal ventricles, the two ventricles, the right ventricle primarily delivers its output to the placenta for oxygenation purpose, and the left ventricle delivers majority of its output to the heart, brain, and the upper part of the body. This is the basic concept we understand, and that is the reason we always say that it's a parallel circulation which is happening. How does it happen? From where the shunting happens despite having all those four central shunts, we'll have to understand the venous blood flow patterns which is there in the heart and the arterial beds to which the heart has to pump. So there are 6 central venous system. SVC, superior vena cava, which receives blood from the upper part of the body. We have coronary sinus, which actually is draining the myocardial flow. The ductus venosus, which receives most of the placental blood from the umbilical vein, which we have already learned. The IVC has got, which is below the hepatic veins. This receives blood from the lower body, and hepatic veins, which receives portal venous and the hepatic arterial. So we shall be seeing in the schematic diagram so that it will be easier for us to understand. And pulmonary vein, which is receiving the pulmonary blood flow. There will be some repetition in this slide as well, so as to understand, because we have to understand the concept slowly and build it up. So these are the 6 central venous system where which we understand. So the same thing if we look at in this photograph, where can I use my pointer? लेजर कनेक्ट हो जाएगा क्या इसमें? Okay, yeah, thank you so much. So in this schematic diagram, where we can see that this is the right atrium which is receiving the blood moving to the right ventricle. From the right ventricle, it is going to the pulmonary vessel by passing through ductus into the descending aorta. The flow, the oxygenated flow from the placenta via the ductus venosus is getting into the LV, and thereafter it is getting pumped into the aorta, the upper part receiving the better oxygen. This is the basic concept that we'll have to keep reiterating it time and again. So the first central venous system that we have to see is this SVC and the coronary sinus. What actually happens, the anatomy or the structural design of it is so that the blood flow which is coming from the superior vena cava and the coronary sinus, this is the superior vena cava and the coronary sinus, it actually drains directly into the RV. The anatomical makeup drives the blood directly into the artery so that there is a less mixing, because this is a unoxygenated blood. So we'll see that almost all of the SVC and the coronary sinus blood flow goes into the RV. If we see the IVC and the right hepatic vein flow which is there, so the upper IVC, which is inferior vena cava, is actually what it is formed by the lower IVC, which is coming down from along with the right hepatic vein, which is draining the right lobe of the liver, plus the left hepatic vein draining the left lobe of the liver, and the ductus venosus. So what actually is happening, that the blood which gets into the umbilical vein bypasses through this ductus venosus, as well as supplies the better oxygenated blood to the left lobe of the liver. These two, they all join and they form the, so what we call it the upper IVC draining into the right atrium. So what actually is happening, that there is a very fascinating streaming of the blood which happens, wherein the blood which is coming from the ductus venosus and the LHV or the left hepatic vein streams in such a way that it gets through the foramen ovale directly into the left ventricle. So the two things that we learned, one was the anatomical makeup was such that the blood from the SVC and the coronary sinus was draining directly into the RV, and the oxygenated blood coming from the ductus venosus and LHV streams in a flow pattern where it gets directly into the left ventricle. So this is a peculiar characteristic which the fetus has, so that it is able to handle and give the oxygenated blood to the upper part of the body. Okay. So this is the lower IVC and RHV drains join and course into RA along the inferior margin of the stitution wall, which direct most of that flow along that of the SVC across the tricuspid ward into the RV. This we have already learned. Okay. Now moving the next. The third part that we have partly discussed is the ductus venosus and the left hepatic vein, which has got a better or a oxygenated blood. The ductus venosus actually receives most of the blood which is coming from the umbilical vein. Almost to the tune of 2/3 or 60% of it, it bypasses through the ductus venosus, and it ductus venosus and enters into the upper IVC along the medial margin. So what it does, actually it has got a flow which let the blood get directly into the RV. This is partly attributed. So what happens? These two highly oxygenated blood streams flow together into the RA along the superior margin of the stitution wall, gets along into the foramen ovale and reaches the left atrium and thereafter into the left ventricle. Why is it happening? One is this flow pattern which is there, this anatomical benefit that the fetus has to streamline the flow towards the LA, as well as the flow, the speed of the flow is much higher. It is said that the high velocity of the ductus venosus flow, which is almost to the tune of 55 centimeter per second, led this streaming of blood happening into the LA and thereafter into the LV. To sum it up in this, we have learned that all these blood which is oxygenated from the placenta gets into the ductus venosus almost to the tune of 60%, wherein it joins the LHV and the oxygenated blood because of the high flow. The anatomical preferential flow happens to the LA and to the LV. Vis-a-vis the deoxygenated blood from the SVC as well as the coronary sinus gets in, because it enters from the lateral aspect, it enters the RV directly. So this is what we have learned till now, and this is what is depicted in this photograph. Okay. Now the blood has reached the RV and the LV, correct? In a preferential manner, the oxygenated and the what happens thereafter? So the lung has got a very high vascular resistance, and the lung is of no use because the placenta is working for the lung in terms of gases exchange which has to do. So the lung has got a high pressure requirement, and the flow to the lung is only to the tune of 10 to 15% combined. It says the only 10% of the LV output traverses through the aortic arch and supplies to the thoracic aorta. The aortic isthmus, what is the narrow part, is actually the resistance. It's got a high pressure, and that is the reason it causes the blood, the flow of the blood through that isthmus is decreased. Whatever flow it comes down, it has been seen that 55% of the flow in the descending aorta gets into the umbilical artery because it has to get back to the placenta. So the loop has to be completed. That means whenever the blood has reached the LV will pump the blood into the aorta, the arch of the aorta. The blood will oxygenate the major, what is called the brain and the upper part of the body. The blood moving down gets mixed with what? Because the ductus arteriosus is connecting. So the ductus arteriosus does what? It takes the RV wala blood mixed with the LV wala, but this is beyond the isthmus. So the blood which is moving down is deoxygenated, and it has to get oxygenated, and that is the reason most of the blood from the descending aorta gets into the umbilical artery and then to the placenta for oxygenation, and rest it perfuse the lower part of the body. So the lower part of the body is perfused by a relatively less oxygenated blood. Correct. Okay, so this slide purposely I have just kept the image just to make it understand that the fetus is actually in a hypoxic state if we look at the PaO2s and the saturation inside, but which is required. we have to understand that there is a lot of mixing which is happening, and despite that the fetus is surviving in the optimal environment, it has got its own way of handling it. These are the various percentages and the SpO2 which is there. We don't need to remember each and everything. Only thing that we need to remember is that the PaO2s and the SpO2s are pretty less in the fetal circulation as compared to the neonatal and the childhood circulation. So this is the final, what happens, that what is happening is that the okay. So this is the oxygenated blood which is moving into the liver through the ductus venosus. It is getting into the right. This is what RV, the preferential flow happening through the foramen ovale LA, getting into this, circulating the into the major circulation, moving down where it is getting mixed with the ductus flow, which is making it deoxygenated, finally moving down into this umbilical artery. This is just a simplified video where you can learn what happens actually before birth. Now, this is the circulation or the physiological part we have learned, and how does the ventricle pumps into it, correct? The second thing that we have to understand, the other handicap or what is the peculiarity about the fetal heart, is that it has got 60% of non-contractile element, and as compared to the adult, and the number of even sarcomeres are much less. If you look at the other physiological parameters, there is always a what I would say is a handicap with the fetal myocardium, and there is a poor sympathetic innervation to the fetal myocardium, which actually keeps improving as the day passes postnatally. What is the clinical relevance for it? We'll have to see that the cardiac output in an adult or a child is primarily dependent on stroke volume and heart rate, correct? So the LV contracts and the stroke volume increases thereafter. Vis-a-vis our fetal and the neonatal part in the early, they are heart rate dependent, correct? So that is the reason we have a heart rate of 140 in our newborns as compared to 60 or 70 as the child grows. The Starling response is what? Basically, it's a physiological phenomena wherein there is, you fill in the ventricle and then it has to pump the blood out. So that response has got a limited capacity in case of a fetus and the neonate as compared to the adult. Rest we don't need to understand. So these are the two things that we need to understand, that the fetal heart rate and the neonatal is basically a heart rate dependent circulation, the cardiac output. Okay. Now a word about fetal PVR, because the day has to be built up on this concept of a higher PVR and a PPHN, which you need to address. The fetal circulation has got a high pulmonary vascular resistance, and this is a multifactorial, because there are multiple factors which is pitching into the creation of a high pulmonary vascular resistance. One is that the lung does not has the function to perform for the gaseous exchange. The anatomical vessel characteristic, which is increased tortuosity, kinking, the high muscular mass, and the high vasomotor resting tone of the pulmonary vessel, which leads to high PVR. The collapsed fetal lungs also has got a low resting O2 tension, which is an indirect, which means that we all understand that the biggest dilator for a pulmonary vasculature is oxygen tension. So if the oxygen tension is low, this will all cause a decreased pulmonary vascular resistance. And the PVR changes is affected by the change in the pH, PCO2, and the autonomic system. At this juncture only, I would like to say that when the lung is developing, what is happening, the vessels are also developing along with it. So the pulmonary artery which is developing, it has got a vessel which keeps branching, and finally a capillary loop which is made around the alveoli, where we have the alveolar gaseous exchange keeps happening. So the vessel has got intima, media, and externa. So whenever a change will happen, whenever a interruption will happen, there will be remodeling of the vessel, which I shall be covering in the subsequent slides and thereafter. So the second thought, the first concept that we learned till now was the structural and the physiological variation in the flow, which led to have the fetus surviving in a relatively hypoxic environment. The myocardium was not so well formed, I would say. the heart rate was taking over all these things. And the third is that the PVR in the fetus is much higher and is because of the multiple factors. So the high PVR has to be understood. Okay. What about the physiological process which happens that despite the fetus having in the relatively low PO2 environment, how does it happen? So we all understand this curve, which is the oxygen dissociation curve, where and we see that increasing PO2 leads to increase in the oxygen saturation. When the curve moves onto the left side, what is happening at even at a low pressure, there is an increase in the oxygen saturation. So what actually is happening in the fetus? We'll The fetus has got two things. One has got a hemoglobin which has got is got a hemoglobin F which has got a different structure as compared to adult hemoglobin, and these two the change helps the fetus to have a better or a more affinity to the oxygen. So HbF has got more affinity to the oxygen. So what actually is happening, and plus simultaneously the hemoglobin concentration is much higher in the fetus. So what actually happens, the maternal side, if you look at, which has got a high level of oxygen, and the fetal side has got a low level of oxygen. So what happens? This leads to the HbF binds to the oxygen in a better way and carries the oxygen to the tissue which is there. The affinity is not very high, but it is much little higher than the HbA fraction. The CO2 is a very diffusible gas. So what happens the moment CO2 moves from the fetal to maternal side, the curve shift, the increase in the CO2 level will help in what? It will help in better binding. The curve will move to the right. So the presence of high HbF, high concentration and the HbF helps the fetus in a better oxygenation despite having in a relatively hypoxic environment. Okay. So this was the basic about fetal circulation that we have understood. We will have to move what happens in the transition period. That means when the baby is to be born. So there are three critical adaptation which has to happen to have a smooth transition. The first thing is what? The pulmonary blood flow, which increases tremendously, and it is to the tune of 10 to 20 times the pulmonary blood flow increases. The central blood flow pattern that we have all seen, that there are multiple shunts which are there, so they have to get closed, so that now this the circulation so called that we said was a parallel has to get into the series circulation. The need for the baby has increased because of the increase in the energy requirement. So there were the baby was just lying in the uterine cavity, getting everything from the placenta. Now the newborn has to work for to have the extra output or the extra energy for multiple metabolic demands. One is the increased work of breathing. Even the temperature was very well maintained inside. The baby has to now come into the outside world, which need to have extra demand for this. So all these metabolic requirement is coupled with the increase in the ventricular output, which has to happen in the transitional period. So the three thing was the increase in the pulmonary vasculature, because now the lung has to act like a gas exchange unit. All the shunting has to get closed so that the circulation moves from parallel to series, and the pumping has to happen into the systemic circulation. And for that, we need to have the increased cardiac output from the left ventricle, so that the additional requirement is also met with. So these three things we'll be seeing one by one slowly. This way, if we see in a simpler way what happens, the moment the baby is born, there is something called alveolar fluid extraction, or the fluid filled lung is actually getting into the aerated form. Why does it happen? If we go back to the physiology, we all understand that in the initial part of the gestation, what is happening in the lung, there is a chloride based secretion of the fluid which is happening into the lung. When the fluid gets into the alveoli, it stimulates the growth of the lung. Correct. So why the lung is filled with fluid? Because it has to grow, and the growth is because of the pressure or the volume of the fluid which gets. So this is one of those factors which leads to growth of the lung. As the gestation advances, the sodium reabsorption process starts. That means it is sodium mediated reabsorption of the fluid, because now the lung has to get used to handling the air inside. Correct. So the first step which happens is the alveolar fluid clearance. Correct. So what happens? There is expansion of the lungs happens with the breath that the baby takes. So the pulmonary vascular flow increases, the vascular resistance decreases. This will cause the return to increase return to the LA. So the LA pressure will increase. What will happen? The foramen ovale, which was the sun, because of the flap mechanism, it just closes. Correct? So this is the basic thing that we have to. In the lower part, if you see what happens, we are just clamping the or cutting the cord. So the placenta, which was a very low resistance, high volume content, that has to get closed. So the systemic pressure increases. And now the heart has to work in series. The other shunt which closes during this time is what? The moment you clamp the umbilical vein, the umbilical cord, the umbilical vein circulation also ceases. So this ductus venosus, which was receiving almost 60% of the fluid, has to close. So that will also close. The entire process will lead to what? The fetus was in the hypoxic environment. Now you are giving oxygen, oxygenating the lung. So the PaO2 will start rising. Along with other factors, the ductus will start closing in response to it, and the PVR becomes low. So the all the shunt reverses and closes. So this is the basic physiological transitional process which happens soon after birth. So the same thing can be in this, where we have learned that we have cut the cord. When the moment we cut the cord, the the flow pattern changes, and we can see that the entire circulation has become in series, where the deoxygenated blood is coming into the right side of the heart, getting into the lung for purification or the oxygenation, moving back to the LA, and thereafter pumping, which happens. Okay. So a little more, because now we are getting into the PPHN mode. We have to understand that what actually happens. So what is happening when there is how does the fall in PVR at birth happens, and what actually, the moment there is an increased pulmonary blood flow, the oxygen is getting into the alveoli. Oxygen is a very potent vasodilator. So the vessels which are present all around, they start dilating. It is said that the 2/3 of fall in PVR happens immediately or in the first few hours or the first 24 hours of life. There is, this is one, that means the alteration in the oxygen content, which is a potent vasodilator. There are other pathways which are existing, which add to the pulmonary vasodilator. These are the site where we need to intervene, and the subsequent lecture will you'll come to know that where to the drugs, these are the targets for therapy. So what actually happens, whenever there is a distension of the alveoli happens, the prostacyclin gets secreted. So this is because of the mechanical stimulation, which is also a dilator, correct? So the the biggest dilator, I would say, is the oxygen, followed by we have a prostacyclin which gets secreted. There are other, which is a nitric oxide inducible and expressible pathways, which we'll learn in detail in the subsequent slide. They also has a role to play in the pulmonary vasodilator, which keeps happening thereafter. The other pathway is the GMP pathway, which is mediated through phosphodiesterase, which also gets into action for pulmonary vasodilator. So we understand that oxygenation, we have the prostacyclin pathway, we have the cyclic GMP and the phosphodiesterase pathway, and the nitric oxide pathways, which are there in the endothelium or the cell, which helps in pulmonary vasodilatation. Correct? Okay. So this takes place in the acute phase, or in the first, let's say, 6 to 24 hours. What happens thereafter? There is a remodeling of the pulmonary vasculature, which keeps happening. So there is a decrease in the muscularity of the proximal arterial bed and increase in the muscularity of the distal. So this is the remodeling process, which helps in decreasing the PVR further. And that is the reason we all have learned over a period of time from our MD days, that why does the CCF manifest at 6 months? Because the pulmonary vasculature keeps. So this is the remodeling process which keeps happening, and the PVR keeps dropping down by around 6 weeks of age. Correct? So this is the mechanism for a slow fall in PVR, which happens thereafter. In this we can very clearly see that what actually is happening, that there are 3 graphs. This is the number of week postnat, this is the birth, this was the pre, and this is the, so postnatally what is happening, the PVR is significantly decreasing by around 6 bucks, it has come to minimal, and the blood flow, which increases to the max immediately in the first, soon after birth, or just in the first or 2 days, which is maintained thereafter. Only the PVR keeps decreasing down subsequent to the remodeling of the pulmonary vasculature. The second part, which was, so the first, what was the decrease or the PVR or increase in pulmonary blood flow? The second was the, all this shunt has to get closed in the transitional circulation. And how does it happen? We'll see the umbilical artery flow has ceased. So that means there is no flow which is happening to the placenta, correct? The pulmonary vein has also gone. So the ductus venosus has closed. It has to close. I'm not getting into what time it closes, how does it close. We'll have to assume that it has closed for a normal transition to happen. The LA pressure has increased and it has shut the foramen ovale, which has led to the almost closure of the foramen ovale. The a word in detail about the ductus arteriosus closure. This is the closure happens from 12 to 48 hours. The major determinant which closes the ductus arteriosus is the increase in the oxygen concentration, which leads to it. There are other pathways which we'll discuss in little detail. What is the arachidonic acid pathway? What we say the prostaglandin pathway. Correct. The other ones are the bradykinin, the catecholamines. What actually happens? What is keeping the ductus patent in the fetal life is the high prostaglandin, which is called the PGE2. PGE1 we give in the postnatal life to let the duct open whenever we have a duct dependent systemic or a pulmonary circulation, correct? In the uterine, in the fetal life, the PGE2, which is being produced from by the placenta, correct? The placenta produces and it keeps the duct open. What happens in the transitional part when the duct is when the cord is cut? So now you have decreased the production factory, so the PGE2 level will get down. And the second part, the PGE2 has to get metabolized, and the enzyme which is there is in the lung, correct? So the lung flow has also increased. So what happens? The production has also come down and the metabolization has reached its peak. So the PGE2 level will increase and this will cause ductal closure. So what will happen whenever you have a lung disease or a difficult transition? Which the production will has come down, but the metabolization will not be as appropriate. So you will have a duct which will be open for a longer time. So the lung disease will cause some amount of difficulty or a delay in the closure of the ductus. Okay. So this is about the second aspect. First was the pulmonary blood flow changing. The second was the closure of all the major shunt which is there. The third is what? There is a ventricular output increases. Why it has to happen? Because there is an increase in the requirement by the fetus because of the increase in work of breathing as well as the thermoregulation which now the baby has to do it. So how does it happen? So now the left ventricle is coupled to the high resistance systemic circulation because now the SVR has increased, the low pressure placental circulation is out. So and now it has to act against a pressure with an increased flow which the LV is getting from the LA because of the increased flow to the lung. So now it has to start working and it keeps pumping the blood. Okay. So this was till the transition which has happened. So the fetal part, the transition which has happened, what happened? What are the common clinical problem or the difficulties if we face in the transition? What is going to happen? So we'll discuss just one, 2, 3 slides more. So what happens if there is a ductus? This I've just kept 2, 3 clinical scenario when the one of them is a ductal closure in the antenatal period because of the mother receiving some NSAIDs. So you give it. So what will happen? There will be increase in the smooth muscle development, which will result in the elevation of the pulmonary vascular resistance. So what will happen if there is increase in the PVR? So that will be relatively normal PVR, there will be a delay, or I would say the fall in pulmonary vascular resistance, which has to happen soon after the birth, it gets affected. So whenever we have a child which has, whenever a mother which has been exposed to NSAIDs, we have to be relatively looking at the delay in the fall in PVR, which is likely to happen. So the second part is what happens, the response to the fetal hypoxia, which is happening inside. The fetal circulation response through the neural and the endocrine response. And what it does, the response to hypoxia is bradycardia. And we all understand that the heart rate dependability is too much on the fetal cardiac output. So it will decrease the fetal cardiac output and will cause this will orchestrate a circulatory redistributional pattern which will maintain the placental circulation. And what will in turn it will do, it will only perfuse the major or the important vital organ that we say. So what is happening here, the same all these Doppler process, the AEDF, REDF, increase CPR and ductus venosus. So this is where the hypoxia happens and the Doppler abnormality starts coming in. This is the second last slide, I would say. So what whenever there's a transition delay, and what are the clinical condition where there will be a transition delay which will happen? One is a preterm birth, a simple preterm birth. The preterm as such, because of the prematurity, has got a immature developmental handicaps which has got, along with the respiratory disease because of any region which the newborn, most importantly the hallelujah. So what will it do? It will cause delay or a decreased fall in pH, PVR. So there will be a PPHN or a pH associated with. So the clinical condition where you could get a pH is in one is a preterm birth. Second is neurological impairment. So neurological impairment could be because of asphyxia, simple. It could be because of any myopathy or the disease, SMA-like disease which the newborn has, which has led to a hypoxia in turn. So all these things will cause what? That will interfere with, because the baby has not taken a well-sustained, good breathing effort, which has led to the alveolar expansion. So there is a interference with the alveolar fluid clearance. The lung is not inflating, and therefore the pulmonary vessel is likely to be higher, which will lead to PPHN. The other clinical condition that we encounter commonly is what? Meconium aspiration. So there could, which is primarily it's a mix of multiple things, hypoxia along with the blockage, which means you have a ventilatory issue. So the ventilation may be affected because of the luminal block, the meconium, which is causing obstruction, or it could be because of the other pulmonary malformation or any external compressive malformation. So anything which causes blockage of the airway, that will indirectly lead to the increase in the pulmonary vascular resistance. And the other thing is a pulmonary disease, which we have already learned is a HMD, or any other thing like pneumonia, hydropic baby with a effusion. All these will have increase in the pulmonary vascular resistance. And the increase in the pulmonary vascular resistance is what we are going to discuss in the subsequent classes, is the PPHN. And to summarize, we have to see, we know that secondary to impaired or delayed relaxation of these vasculature leads to what? Pulmonary hypertension, which has been broadly classified into two, primary and secondary. Primary accounts in which we have a normal parenchyma with an abnormally remodeled pulmonary vasculature. And the secondary is all because of the clinical condition which will hamper or will delay the transition, like parenchymal disease, asphyxia, or hypoplastic lung, which is associated with CDH or other condition. So this will lead to PPHL. I have completed. And I would just to summarize, I would say that fetal circulation is a low saturation, high HB circulation, which helps to survive the fetus in the hypoxic environment, has got a high PVR, low SVR, with central shunt running parallel with a RV dominance. In the transitional circulation, the closure of the shunt happens, leading to high systemic vascular resistance, fall in SVR, and any antenatal or perinatal event which will alter this transitional circulation will lead to increase in PVR and therefore PPHN, which needs management. Thank you so much. Thank you, everyone.